Now I would like to welcome the presenters for this intensive. We have Patti Kritzberger, Health Information Technology Quality Improvement Specialist, has 27 years experience in health information technology, is certified in healthcare privacy and security, and as an RHIT. She is currently working for Quality Health Associates and under contract with Health Tech Solutions as an outreach coordinator for the ND Health Information Network Expansion Project. Patti has held positions as REACH Coordinator, Assistant Director of Health Information Director, Privacy Officer, and HIM Coding Consultant. Patti has also served in the offices of President-elect, President and past President, Education Director, and Membership Director of the North Dakota Health Information Management Association. We also have Sarah Miller. Sarah is the North Dakota Health Information Network Outreach Manager and HIPAA Privacy Officer. She works with the NDHIN outreach team to connect with healthcare providers and payers throughout North Dakota. She is dedicated to improving healthcare by creating a secure medical record sharing network for providers and patients, and they aim to empower patients by ensuring their medical data remains safe and private. Disclosure, the presenters have indicated that this presentation will not include discussion on any commercial products or services and will not include any discussion of off-label and or investigational uses of any product or services and will not include trade names. Patti and Sarah, the floor is yours.
Thank you, Anna. And hello, everyone. Welcome to our virtual 2021 Dakota Conference, and thank you for attending our session. As Anna stated, I'm Sarah Miller, and I'm joined by Patti Kritzberger. We will be sharing the presentation today. I will be starting it off. And we are happy to be here today to provide you a background on the North Dakota Health Information Network, which you will hear us refer to as NDHIN throughout the presentation, talk about our expansion project, and highlight the successes of the outreach work we've been doing. So our objectives for today are to review our history and background of NDHIN, explore the features and functionality of NDHIN, and describe our NDHIN outreach program and expansion project, and also to summarize the success of our NDHIN outreach program. So we will get started with some history and background of the NDHIN. So what exactly is NDHIN? NDHIN is a division of the North Dakota Department of Health, a network model statewide health information exchange, or HIE as you may have heard it referred to as, providing value through a secure online network for electronic health information exchange, a robust patient data set, and an increasing number of connections among North Dakota hospitals, providers, and other related entities. It is a longitudinal health record, and it's information over time and across organizations. NDHIN provides patients health information to create a comprehensive health record for treatment purposes. And also to create a chronological roadmap of data for a more thorough understanding of patient conditions, which allows for up-to-the-minute decisions and faster diagnosis. North Dakota NDHIN reduces patient intake time, minimizes duplication of services and unnecessary paperwork. This slide will depict a timeline from the initial environmental scan to where we are now. It all started in 2008 with an initial environmental scan of the status of the use or opinion of the use of e-health technology. In 2009, state and federal funding appropriations were acquired for the project. Over the next few years, a vendor was selected, participants were recruited for using NDHIN and sharing their data. In 2016, there was another environmental scan to gauge status of the use of NDHIN and e-health information technology. From that, a business plan was developed, and part of that plan was a major upgrade to the NDHIN platform, which was done in 2019. This slide illustrates the many points of transitions of care for anyone, regardless of living independently or in some type of assisted living or long-term care facility. At any of these points, there is a chance for a breakdown in communication and could leave a gap in the patient's information. This could create a gap in their care and cause them to fall through the cracks. So think of these points of care in your own community organization in which you have staff that need information and are taking time completing release of information forms, making phone calls, standing by or checking the fax machines for that information to come back to you. Think of also the time that the tertiary hospitals must spend disseminating the information with all the requests that they receive daily and how long it takes to receive the information once it's been requested. This is an illustration of how a patient's healthcare encounter information is sent to and organized by NDHIN and matched up with the patient's demographic information and made available in the cloud where it can be retrieved by NDHIN clinical portal users. You'll see that we have the data coming in from hospitals, clinics, diagnostic and imaging centers, or emergency departments. That information comes into NDHIN, and we assemble that using a master patient index to match up the patient demographics. By aggregating the electronic records available across the community and putting the information into a format that's useful, NDHIN eliminates the time-consuming process of retrieving such records via phone call, mail, or fax. I'll now turn it over to Patti to share the features and functions of NDHIN.
Thanks, Sarah. Do you want to give me a thumbs up if you can hear me? Okay, perfect. So now we want to showcase some of the features and functions of the NDHIN. This slide here is a summarization of all the features and functions in one spot. When you search for a patient record when you're in the clinical portal, you can find the information that has been shared with NDHIN in the column on the left that you're seeing. And so that information includes allergies, medications, any encounters that the patient has had at other facilities, whether it be within North Dakota or out of North Dakota. And then you can also see results, lab results, radiology reports, transcribed documents. You can actually see images. We have Alltrue and Trinity and their affiliates are actually sharing images with us that you would be able to see. You can access the prescription drug monitoring program and then also have access to the eHealth Exchange. And so we offer the services that are shown in the right-hand column there. We have enhanced access with the single sign-on capability, which allows a user to launch directly into the NDHIN from the EHR that they're using. And we also have the capability to set up encounter alerts and notifications. There is some public health reporting that goes on in the background of the Health Information Network, and these are public health reporting such as your syndromic surveillance, your electronic lab reporting, and your immunization registry. We do have an autism registry, and an additional value add for participating in the NDHIN includes access to our DSM, our direct secure messaging functionality, and we call that Communicate. That's what we've named our solution there. And then this can be used to securely send any electronic health information and other sensitive messages from point to point. And here are some different kinds of data feeds that we have available or that participants can choose to share with us. So first of all, I want to talk about the admission, discharge, and transfer data feeds, and that's what in the medical world we call ADT. And what data comes across on that feed is your patient demographics. There's encounter history, as I said before. The allergies are noted, diagnoses are noted, procedures are noted, and as well as medications. And I see that I do not have this included on the slide. And so we start with the ADT feed. So like as Sarah said, we can have a patient matching. We can have that electronic master patient index. So records can be matched up to the same patient when information is coming in from different entities or various facilities. Our medical document management, which is our clinical documents, these include discharge summaries or encounter summaries, histories and physicals, emergency department visit notes, and some of your operative reports and consult reports. And as we said, and we'll talk about as we go through this, some facilities are exchanging that information or, sharing that information with us, and some are not. And then lastly, we're going over to the right-hand side here and looking at the observation results, which we call ORU. And these are your lab results, radiology reports and documents, and then again, some imaging studies. And when we set up these data feeds, the NDHIN provides a connection on our side. However, the EHR vendor is going to pay a fee for their portion of the interface. And we do currently have some funding available in the form of an IAP or an Interoperability Assistance Program grant. And Sarah is going to talk about that a little bit later in the presentation. Now we want to talk about our current services. And I've already touched on the access via single sign-on, or we have website access. So what happens here is with single sign-on, again, you can launch directly into the NDHIN from the EHR that you're using. So for instance, if you're using an Epic product or another health information or an EHR, you can put an icon or some kind of an area that you, maybe a tab on the EHR that you can just go directly into the NDHIN. Otherwise, we do have the website access, and that's just, basically just going out to our URL and putting in your access credentials there. And so with the secure data sharing, the patient community health record includes allergies, past encounters, lab results, radiology reports, and the clinical documents. And we're calling them a community health record because now it contains, things that you would see in a modern day or a current day medical record chart, but we're hoping that we are going to encompass more than just that traditional clinical data coming, including info from public health agencies, chiropractors, and those types of things. To talk about the PACS, that's the Picture Archiving and Communication Systems, and that again is referring to the radiology images. We do have an e-health exchange, and some of you might be familiar with what was called the Sequoia project, and what it's called the e-health exchange now, and it allows access to external health exchanges across the nation. Again, our direct secure messaging, this provides a secure email type of functionality to exchange information with others who have the DSM. And we are currently working on a provider directory for that. Now I want to talk about some patient medication information. We find this to be very beneficial in healthcare facilities when it comes to medication reconciliation. We draw information from Dr. First, which includes SureScripts information from across the state. And so providers and pharmacists can access the PDMP directly through the NDHIN, and this will allow them to see the NARC scores for the patients. You can see all of the scheduled drug prescriptions, and by virtue of a simple zip code, I know in one of the breakout sessions there was a MAT treatment table, and so just by putting in a simple zip code in the PDMP, you can find a MAT treatment center that is close to the patient. So that's one thing that is very helpful. And then the NARC scores, they're in the PDMP and they exist for narcotics, sedatives, and stimulants. And so what these are, they're just primarily designed to draw awareness to the presence of any significant PDMP data that the provider or this might be seeing. And they're not abuse scores at all, but they, you know, depending on what those scores are, they should raise concern and possibly trigger a discussion with the patient. Community health service, again, we do connect directly to the North Dakota Immunization Information Systems, and this connectivity is going to show immunizations either from a child or an adult, the ones that they've received and what they're due for. And we found this to be very important in the COVID work. And the electronic lab reporting and the syndromic surveillance services help your practice meet interoperability requirements for some of the quality payment programs. And syndromic surveillance monitoring, that's going to be your measles, your influenza, and now COVID, and that helps to keep track or keep tabs on the spread of the disease. And then the ELR, the electronic lab reporting, that is for the mandatory reportable lab. What I'm showing you now is I've included some screenshots from the clinical portal so I can give you an idea, a little bit of an idea of what you'd be seeing in there. There's going to be a little bit different look if you do have single sign-on. So for this presentation, we're going to the web-based access screenshots. And so when you're searching for patient information, this summary page here, the patient summary page, will be your landing spot when you sign into the NDHIN. And on this page, you're going to see up here, you're going to see demographics, a snapshot, and then right up in this corner here is other identifiers. That is like other facilities that the patient has been seen. There's emergency contact information here, demographics like your address, phone number, and then you're also going to see your primary care providers. But we also, on the patient summary page, can see the allergies, some problems, and then encounter history. And also, there is an area that lists procedures such as EKGs and stress tests, but I did not get that included on the screenshot, unfortunately. But I just want to bring your attention to the encounter history here. You can see the admission date and discharge date, the reason for admission, a discharge diagnosis, what the visit type was for, if it was a specialty, was it a nephrologist, was it an endocrinologist, the facility that they were seen at, the clinician that saw them, and that information. Now we want to take you into Medicines Viewer. And as I said before, we do draw information from Dr. First, including SureScripts. And so the medications, as you can see here, they list in a display format, and each of these can be expanded. So I've shown the screenshot with this acetaminophen right here being expanded. And so what you're going to be able to see here is you're going to be able to see the name of the medication, the instructions, and if there's an applicable different route that the medicine is going to be administered, the supply quantity, the day's supply, and the action date, which is the fill date, and then who prescribed it, and the source is the pharmacy filling the script. So this data can be used. Why I wanted to expand the acetaminophen here is we can, I think it might be too small to see unless but on the handouts you should be able to see it. But for your day's supply, you can see that he's getting the patient is getting 30 days supply here. And so on the action date, you can see that it's the 8th of July of 2019, the 7th of June of 2019. So you can see, you know, if that patient is being, is compliant with his medication routine. And so that's what you're going to see on the med viewer. Now, going to the lab results, this page is going to reflect any laboratory results, and then they're going to highlight the abnormal results in red. And so, as I've shown on this screenshot, if there is more than one result noted, you can go along and check these boxes here, and then those results can be graphed. So you can, sometimes it's a little easier to see the data when it's graphed to see if there's any trends or tracking that you want to do. And you can see here that there's a symbol sign on some of these, or a section symbol. So this means that the ordering facility might have a slightly different reference range for the normal or abnormal findings. And you might see a different reference range when you're dealing with like a nephrologist or an endocrinologist. You know, if you're having, you know, like chronic kidney disease or something, some of your lab functions are, your renal functions are going to be slightly different for some of those patients. But we do have them identified on the screen there. So radiology reports, this on the side, this is where you're going to find up a typed up radiology report. It's pretty self-explanatory. And then we're going down here into other transcribed documents. And again, this is where your H&P and discharge summary procedure notes and things would be. And again, that's something that a facility would have to share with us or interface, send those data feeds in order for you to see them when you're querying. On this slide, I just wanted to depict how an actual image can be accessed here. And along the bar at the top, the toolbar, you can see that there's a number of different tools available to be able to mark up that image. Maybe they want to measure certain areas or even share it with another physician. So this is very helpful if you have something that, you know, maybe your primary care physician is seeing that would like to consult with a radiologist or orthopod or, you know, whatever. So that's a helpful feature. And so here's the prescription drug monitoring program, the PDMP. And we have this for Cameron test patient, but at this time, physicians are permitted to view the PDMP directly through the NDHIN, and pharmacists are. However, nurses, you're able to act as a proxy for a physician, but at this time, the nurses would actually have to go out to the dedicated website for the PDMP to access the PDMP for the provider. And this is how the North Dakota Board of Pharmacy has wanted us to set up the permissions for this. In this area, the eHealth Exchange, this is where a clinician could search for out-of-state health information exchanges or facilities. For example, there, you know, you can see the Alaska eHealth Network here, or the CalRIO, which is the California Regional Health Information Organization, or like Cedars-Sinai, just strictly that facility alone. So that's what I'm showing you here. And now we want to talk a little bit about this picture is showing how the health information exchange hubs, are connected across the country to allow data to be securely exchanged across these state lines that you're seeing here. So in July of 2020, the NDHIN completed their testing with the regional hub of what we, you can see it up here, the Strategic Health Information Exchange Collaborative, and we call it CHIC. And so this is a nonprofit national consortium of statewide, regional, and community health information exchanges, as well as strategic business and technology partners. And so the CHIC's patient-centered data home that we're looking at here, it allows for exchanging patient data between 45 health information exchanges to improve care coordination for roughly 177 million patients by enabling that nationwide access to that data. And a nationwide connection like this really allows for that seamless delivery of patients' health care or patients' health information across state lines and health systems. And so I just kind of wanted to walk you through the way it works, because it's based on an episode trigger which would alert if a patient is seen in a healthcare facility outside their normal area or home area. So with those episode alert triggers, there's been roughly about 1 billion of them in this patient-centered data home when a patient is seen outside of their home state. So let's use me for an example. Let's just say I was down in Arizona visiting my sister and I ended up in the ER. And so the Arizona care team facility, they would send out an ADT alert to the Arizona Health Information Exchange. And so the Arizona Health Information Exchange sends that alert based on the zip code to the NDHIN, because it would see that I had a North Dakota zip code. And so then the NDHIN would in turn notify the Arizona Health Information Exchange if there are patient records available. And concurrently with that notification, the NDHIN would send that ADT alert to the patient's provider in North Dakota, as long as they were set up in a circle of care. And so then the NDHIN and the Arizona HIE, they would exchange the clinical data on the patient. And so the Arizona HIE would take those patient records and make them visible to the Arizona care team, while then on the backside or the other side of that coin, the NDHIN is going to share a post-encounter summary with the patient's North Dakota care team. So just a little bit, I think sometimes it's a little difficult for people to kind of understand how that exchange works across the state lines. So that's just a little bit of an example. So the NDHIN, the patient benefit. So you're going to have improved care coordination and visit efficiency when you're able to have that rapid information sharing. Again, with the use of the medicines viewer to do medication reconciliation, you're going to get safer administration of prescription meds and, get that more efficient reconciliation done. Reduction in duplicate tests and procedures. An example that we have of that is one of our coworkers, her father-in-law was going to have a procedure in a larger facility, a tertiary facility, but had been seen at a small clinic in their hometown. And it just so happened that that clinic was sharing information with the NDHIN. And so then that provider in the tertiary facility was able to go there or query that patient and see that, yes, he did in fact have these tests that were needed. And so he didn't have to go through duplicate testing for that. Provider notification, again, when significant patient events occur, and we can also avoid the loss of key pieces of patient's health record during unexpected events and disasters. Talk about, all of these ransomware attacks. The first and main goal of health information technology is to improve that quality of patient care, and there are studies to back that up. For instance, there was a study in Texas of Texas hospitals that found that those facilities with more advanced health IT showed fewer deaths and fewer complications of care among their patients compared with patients at hospitals with less advanced health information technology. And, you know, one of the reasons for this is what I alluded to before is, you know, they can see prior test results that are available and only order truly necessary tests. And that's going to, you know, save time, money, and discomfort while reducing risk to the patient. And again, it's all about the patient. And care coordination is improved because of having this information available to all types of providers, your primary care providers and specialists. Home health can be a participant and query that information, public health, and also behavioral health. It eases that transition between healthcare settings. And the HIE can integrate and organize the patient health information and facilitate its instance distribution among all authorized providers involved in that patient's care, and Sarah kind of showed you that. And so all of this should translate into better overall health and better care for the patient. And if we're seeing better overall health and care for the patient, then that's going to be a reflection of the quality of care. Better health and better care should start showing up in your quality scores when you're having to, you know, report some of these things to the quality payment programs. And so the NDHIN benefit to users, this is a list of whys that I've already touched upon, you know, thinking about the points of care that Sarah talked about in her portion at the beginning. And so again, we help with accessing and organizing the available data. And, you know, we can also help organizations in their overall healthcare management, such as the NDHIN can actually be a backup health record if you have computer downtimes. We can augment your disaster recovery and those types of scenarios. So, you know, again, what about the ransomware that is happening now and those types of things? So I guess in the last few slides, we've kind of illustrated that there's very good reason to utilize the NDHIN. And now we're going to go into the expansion project and just touch on some of the things that we've done in the last few years. And so Sarah did discuss the timeline at the beginning, but a little bit more information. In 2017, we started more extensive data feeds with the ADT messages, again, the admission, discharge, and transfer, and the results messages. Then in 2018, we started adding medical documents and immunizations. And this is when we also started being able to exchange the CCD information, and that's like your continuity of care document. And then in 2019, that's when we upgraded the Exchange Gateway to Amadeus. And we did that in order to address the population health issues, social determinants of health, and, you know, just to prepare for those types of things, the encounter alerts and notifications, and then utilization reporting, so we can know who's utilizing our NDHIN. And then in 2020, last year, we have started work on a healthcare provider directory. We've performed assessments in some public health areas and have looked at opportunities to increase interoperability. One of the projects that I was working on was the Cancer Registry Project. And then in 2021, we've got our eye on behavioral health in the 42 CFR Part 2. Interest in the becoming a qualified clinical data registry, and then also looking at our sustainability model. So as you saw in the timeline back in 2016, we did that environmental scan to get a better understanding of and to advance the adoption and use of technology to exchange health information and improve the quality of care or healthcare quality in general, patient safety, and overall efficiency of healthcare and public services in North Dakota. So what that resulted out of that was a 5-year business plan with these major goals. Upgrade to the Amadeus platform, which we did in June of 2019. And then we implemented the active outreach program, which were boots on the ground. And so there are several of us, which we call outreach coordinators, and Sarah is our outreach manager. And what we are tasked with is going out and, you know, engaging with facilities or providers, or re-engaging with the facilities and providers that had previously signed up to utilize the NDHIN. We just, you know, we've made a lot of advancements in the information that we're able to share. We've increased the types of data that are contributed to us that are queryable. And so basically, you know, just increase the utilization of the NDHIN as a whole. And so all of our data was migrated to the Amazon Web Services, and this platform provides the benefits of improved scalability to expand data integration with and improved privacy and security capabilities, and then also supporting the innovation with the API interfaces that are being developed to improve that interoperability. And we are providing a foundation for population health. We have the medication management tools, as you saw with the medicines viewer, and then some more getting some more data analytics and care coordination tools. And we did integrate the PDMP with the NDHIN, and again, you know, with the medicines viewer to support that. And we upgraded to the Exchange Gateway, and we added, that's the state-to-state health information exchange that I showed you, and that's supports our onboarding or soon to be onboarding with the Veterans Administration, Social Security Administration, and the Department of Defense. And so then we added a data analytics module in the form of discovery reports. Now we're able to run utilization reports to see who is utilizing the NDHIN and how often, and then the event notifications where providers would have the ability to set up alerts and notifications for patients that they have a relationship with that would be beneficial in coordination of care. Some additional work that we have in progress, oh, I better hurry up, I guess, is the EMPI cleanup, provider directory, assessment of public health systems, and these others, as you can read here. I wanted to go down to our sustainability model at the bottom, and we did implement subscription fees in 2017 after research and comparing to what other state HIEs were doing at the time. And we want to develop a sustainability model that will allow the NDHIN to remain a viable tool for future use. The high-tech funding that Sarah mentioned, that's going to run out in 2021, and then MMIS funding will be available. So the EMPI, we're going in there to clean up our electronic master patient index where we can cut down on duplicate patients and those types of things, and developing a healthcare provider directory. We are working with the, it should say here, early hearing detection intervention, not detection and intervention, but this is part of the public health scope of work that NDHIN did, and the goal here is to connect stakeholders with the primary care physicians and birthing centers that perform screenings for newborns or children. And so 10 out of the 12 birthing centers in North Dakota are connected to Oz, and that's the platform that they use for reporting screenings, and we're finding that the first screening is captured, but not necessarily the second and third screening. And so the early hearing detection and intervention is at Minot State University. And so they want to interface with hospitals that are performing the screenings, and with the Department of Health as well as audiology. The Cancer Registry Project, again, you know, we wanted to look in to see how we could help reduce provider burden, taking it from a much manual process in hopes of being able to retrieve or, you know, do it on an electronic basis. So we identified the current state, you know, what's going on, what does it look like across the state for the registries. Just look to see if there were any deficiencies or opportunities for better integration or, you know, a better process in providing a roadmap for the modernization of the cancer registry. And so, you know, the current state assessment, what are the interfaces, workflow, infrastructure, future state, how should it look, gap analysis, you know, those are the opportunities to improve, and then the roadmap is how do we get there. Behavioral health, integration of behavioral health and Part 2 data is going to be a priority initiative in North Dakota. We're just looking at how to start including these types of facilities. Encounter alerts and notifications. This is where clinicians can set up notifications for any patient in their circle of care. There's different ways to set it up for delivery options in with DSM, the communicate, personal email. You can set up different notifications types, whether you want to know about inpatient admits or discharges, ED admits, lab and radiology results. We can include, they could be notified for abnormal results or critically abnormal results. And the quality end-to-end reporting, the goal of this statement of work was to provide end-to-end electronically quality reporting program capabilities. NDHIN was interested in becoming a CMS certified qualified clinical data registry to help with Medicaid quality reporting for child and adult core measures. And then after meeting with Medicaid, there's not like currently a direct role for NDHIN in this. However, there are numerous opportunities for the NDHIN to collaborate with Medicaid to improve health outcomes for North Dakota residents. And, you know, there are a lot of requirements that CMS has that have to be met in order to become QCDR. And so NDHIN really fits best right now with being a qualified registry third-party intermediary for submitting quality measures. The QCDR, we could transition into that if we were interested in proposing and developing measures for that. So the sustainability model, we're just going to revisit pricing structure, focus on engagement with our integrated delivery networks. We've had some community-focused efforts in regional meetings. We want to get long-term care, pharmacy, chiropractors, and those types of care facilities signed up, and then getting the Medicaid and payer support along with this. We did a lot of COVID-19 work with that, and so I'm not going to go into this really in depth because Sarah still has some things to work on, but you can definitely see some of the things in the slides, and it's just going to explain a little bit about what we did with the COVID-19 and working with the state lab and some out-of-state labs to get results to flow and just have that information more readily available to facilities. And so we also helped with the reporting to the CDC with using the COVID electronic reporting function, and so we augmented that for the state. And then we did have the alerts functionality for case managers. And so the COVID results coming in had to be organized and reported in a timely and purposeful manner to the CDC, and NDHIN was able to achieve that with the CDLR, but then the caseworkers, they were struggling to follow up with the case management of individuals, and so we were able to set up case manager epidemiologists for alerts and notifications. The outreach program, I just want to give you a few statistics here. From September 19th to the present, we went from 175 business associates participation in business associate agreements to over 400. We do have an increase in our data feeds, as you can see here, from 2018 to present, 361 to 532. And it's telling you, who is contributing data. Local public health units, 71% of the local health units are participating, and 85% of those are contributing data. And we're onboarding EMS, pharmacy, chiropractor, long-term care. This is just a snapshot of where you can see the points of care across the state. And just a data submission graphic. It just illustrates the different data flows that happen within the NDHIN. And some additional statistics with the DSM, the web-based direct communicate services from December 18 to present went from 729 to 1,046 active users. We've only had 14 organizations with the XDR direct, and that's with a single sign-on, so that's pretty constant. And then queries based, the unique patient IDs that we had went from 1,066,000 to 1,429,000 in just a little over 2 years. And then the user accounts almost doubled. So now I'm going to turn it over to Sarah.
Thank you, Patti. Lastly, I'm going to go over some available funding that we have for interested participants, and Patti did talk about this briefly before. So it's our Interoperability Assistance Program, and we refer to it as the IEP program. It's designed to provide financial assistance to healthcare providers that are NDHIN participants and want to contribute data. So the funding that's available is a maximum payment per milestone met is $7,000. And what is a milestone? What does that mean? That means that the integration has been put into place by the vendor on the facilities side of things. And then also they have been invoiced by their vendor as well, and they can show that they have paid for that service. And so then NDHIN will provide monies up to the $7,000 in that grant reimbursement. We do pay that within 30 days of the receipt of the appropriate information, and we do still have grant funds available, and those are available through September of this year, so through September 30th of 2021. So if you're interested in that, please let us know. You can reach out to myself or Patti, or I will show you the rest of our contact information. So here's my contact information along with our outreach team. You can certainly contact any one of us if you have any questions about NDHIN, or if you're interested in the IAP program, we'd be happy to discuss that with you. And then we also have some additional resources listed here in the presentation. The first two are for our website. So we do have a consumer section as well, or a patient section, as well as providers. And if you are a current participant and you utilize the NDHIN clinical portal, we do have a help desk that is available 24/7 at a toll-free number that we do have listed here. And you can contact them at that number, or you can contact them at the email address that is listed. So if you have any questions, please let us know. We'd be happy to address those for you today. and we thank you for joining our session and enjoy the rest of the Dakota Conference.
Good afternoon. I am Anna Walter, and I'll be your moderator for this intensive session, an update on telehealth in North Dakota. This session is split into two parts, with the first part ending at 4:15 and the second part ending at 4:45. I've posted the pre-test for this part one in the chat box, and we'll be posting the post-test as well. So if you'll please remember to take those, we'd appreciate that. If you have any questions during this presentation, please type them in the Q&A box, and we will try to answer them at the end of the presentations as time permits. So at this time, I'd like to welcome the presenters for part one of this intensive. We have Dr. Delage, MD, FAA, FP, is a family medicine physician and is the co-director of the Family Medicine Clerkship and the Rural Opportunities in Medical Education for the Department of Family and Community Medicine at the University of North Dakota School of Medicine and Health Sciences. He graduated from the University of Minnesota Morris in 1985 and the University of Minnesota School of Medicine and graduated in 1989. He attended the University of North Dakota Family Medicine residency in Fargo, North Dakota, and entered clinical practice in Ortonville, Minnesota at Ortonville Area Health Services as a family physician who practiced full spectrum. In 2014, he joined the University of North Dakota. He has interests in rural healthcare, family medicine, global health and healthcare disparities. He has been a member of the North Dakota National Guard since 1989. Disclosure, the presenter has indicated that this presentation will not include discussion of any commercial products or services and will not include any discussion of off-label and or investigational uses of any product or services and will not include trade names. David Schmitz, MD, is professor and chair of the Department of Family and Community Medicine at the University of North Dakota School of Medicine and Health Sciences. He has extensive research expertise in training and retaining physicians in rural and underserved areas, the development of rural communities' healthcare resources. He continues to practice clinically. He is a past president of the National Rural Health Association. Disclosure, the presenter has indicated that this presentation will include discussion of commercial products or services, but neither he or any member of his immediate family has a relevant financial interest or other relationship with the manufacturers of any of the products or providers or any of the services discussed. The presentation will not include any discussion of off-label and or investigational uses of any product or services and will not include trade names. And lastly, we have Dr. Johnson, who is a professor at the University of North Dakota School of Medicine and Health Sciences in the Department of Family and Community Medicine and the Department of Education Resources, where he is the Director of Interprofessional Education and the Medical Director of the Physician Assistance Program. He also serves as the Assistant Medical Director for the Diabetes Center at All True Health System in Grand Forks, North Dakota. He is also a diabetes telehealth care provider in North Dakota and Minnesota. A graduate of the University of Nebraska Medical Center, Dr. Johnson completed his residency in family medicine at the University of North Dakota Fargo program and is board certified in family medicine. As well, Dr. Johnson serves as chair of the American Diabetes Association Primary Care Advisory Board. Disclosure, the presenter has indicated that this presentation will not include discussion of any commercial products or services and will not include any discussion of off-label and or investigational uses of any product or services and will not include trade names. You may begin.
All right, well, welcome everybody to these afternoon sessions. Dr. Johnson, Dr. Schmitz and I work together in the Department of Family and Community Medicine, and today we're going to talk a little bit about telemedicine and telehealth in North Dakota, with kind of an emphasis on what we're doing and hopefully where we might be going. So with that, I'm going to turn it over to Dr. Johnson.
Well, our goal today is to talk about kind of the state of telehealth right now and what the landscape looks like in North Dakota, and a few things that we are doing educationally at the School of Medicine and Health Sciences. I think there are kind of some misconceptions about what telehealth or telemedicine is. Some people just view it as perhaps something like a FaceTime call on a smartphone. And, it can look like that with what are called e-visits, but quite a bit of telehealth and telemedicine care that's delivered is much, much more than that. And you're really creating a clinical experience. It's really much more than just a visit over a phone or a FaceTime call.
And you know what I'm wondering, Dr. Johnson, is that given, oh, Brian's on his way back, but given our technical difficulties, 3 rural doctors can probably figure out something to talk about in between. And I'm just going to give one of the last slides, which induces or maybe brings up a little bit of conversation while Brian works on the technical aspects of the slide. And one thing that I've found from our sessions is those of you who are in the audience can actually enter your questions or comments into the chat. So if it's all right with Dr. Delage, I'm just going to talk about one of the slides that'll be at the end, which asks a couple of questions. What are you doing in rural North Dakota with regard to telemedicine? What platforms are you using? What extra equipment might have you found to be particularly useful? And the other might be, what should we be doing at the university or at the Department of Family and Community Medicine to provide CME for your providers, continuing medical education, or other development that we could maybe help to enhance the use of telemedicine in rural North Dakota specifically? That's a big part of our mission, is to be able to support healthcare services as well as education in particular around those healthcare services. And I think nothing's been more of a disruptive innovator or an opportunity perhaps than this launching ahead that we've seen with regard to the use of telemedicine and technology, in particular in the setting of COVID. So I think we're both interested in what the barriers might be with regard to telemedicine, but also where you are with regard to meeting the patients where they are. What's going on and what does that look like in your rural community, and looking at opportunities to be of help educationally. And so that is sort of something that I think that we want to be able to try to discuss with the audience during this, and also be contacted after the fact. And you'll see our contacts at the end of the session. So maybe I'm the end of the presentation going first, Dr. Johnson, but that might have given us a little bit of time savings here in the end as well to allow you to present your expertise.
Yeah, what we had intended to talk about here at the beginning is what some of the definitions are. And telemedicine traditionally refers to a connection between a provider and a patient. And that can be through some different methods. That can be from device to device, where the patient might be in their home or even their workplace if they have a private space. And the provider may be in their own home or in an office. Telehealth really refers to all exchange of healthcare information relevant to a given patient's care. And that includes the telemedicine portion, but also includes information that might be utilized or monitored another way, like CHF monitoring or cardiac rhythm monitoring, or in my particular case, with my diabetes telemedicine clinics, we do quite a bit with continuous glucose monitors. So I get a lot of that data for interpretation as well. Sometimes in advance of the visit, asynchronously, or sometimes while I'm actually seeing the patient, we can review that together. There are some definitions that are easy to find about what telemedicine and telehealth are. AAMC has some, AAFP does, as well as very soon the American Medical Association, probably this fall, is going to be producing what's called a telehealth playbook. And myself and Dr. Van Eck, another faculty member from the School of Medicine and Health Sciences, have been fortunate enough to be on that authorship group. My personal experience with telehealth and telemedicine goes back to December of 2013, when I was invited by the Heart of America Medical Center at Rugby, North Dakota, to start doing some diabetes telemedicine clinics for them. And this started out as 1 half day per month. We got very busy very quickly. And now typically we're doing 2 half days a month with a few odd patients scheduled here and there throughout the month, kind of depending on their acuity or need to be seen. Things that make that really successful are the diabetes educator actually sits with the patient during the entire visit. And that's really important as well, because you just can't have a patient sitting there alone in a room and expect them to understand all facets of the technology that we might be using for a particular visit. Usually, and that's the case with Rugby, we have HD cameras and HD sound, and we use physician extender devices that allow for a fairly complete physical examination. We have electronic stethoscope, for instance, that I use on almost everybody. And in some ways, the sound quality of that can be better than just using a regular stethoscope in person. Of course, it's also very important with diabetes care visits to be able to do a foot examination. And I am able to do that on almost every patient without a great deal of difficulty with a handheld camera. And if there are some issues that we identify, or the patient is having some other kind of problem, we need a way to escalate them into other care. For example, it's not unusual for me in my telemedicine diabetes practice to have somebody come in with a fresh foot ulcer. Well, we can assess that visually, but somebody really needs to take a look at that in person and maybe prescribe some antibiotics or make a referral to a wound clinic. And typically with rugby, they can be escalated to one of the other in-person providers very easily, usually that day or the next. There have been times that have been a little bit more emergent, where somebody has come in and had a cough and fever, which has really meant a lot during the last year during the pandemic. I have found that with the pandemic, unexpectedly, I went from about 30% of my clinic time being telemedicine to 100%. And for the past 15 months, I've been doing 100% telehealth care for diabetes patients. For my Grand Forks patients, if they need to be seen in person, they can be escalated quite easily to internal medicine or family medicine, really without a great deal of difficulty at all. This has been working pretty well for us. I also had some outcomes data to present to you as well. After we had done rugby for about 2 years, it was our impression that people who were being seen in the diabetes telemedicine clinic had pretty good outcomes and were doing well. And we decided to do a study where we would look at A1C reduction, if any, in the patients that had been seen by telemedicine. And the only requirement for the study was that they had had at least one diabetes telemedicine visit. What we found was that it was about a 1-point A1C reduction just from a single visit with our diabetes care team via telemedicine. So that was exciting to us. Of course, the rugby clinic really liked that, as did Altru, the sponsoring agency for that. So that's pretty much my experience. You know, these look very much like a clinic visit. We check patients in at the front desk. They get vital signs done by a nurse for most of these provider to clinic visits remotely. And one of the big bonuses that's probably obvious is savings of time and driving. I have some patients who drive 100 miles to rugby to be seen on telemedicine clinic. And if they were coming to see me, that would be in the neighborhood of 250 miles. And for some people, that's all day or 2 days off of work. And I have many patients who are never going to do an in-person visit ever again if they don't have to, because it saves them so much time. And I see so many patients from a distance. So that was what I was going to discuss. I can go ahead and turn this back over to Brian, and he can talk about some things that we're doing in education.
Yeah, thanks, Eric. So in terms of education at UND, at the university, Dr. Richard Van Eck and Dr. Johnson are working on this interprofessional telehealth teaching project that Eric talked about. There's also been an emphasis on delivering mental health care statewide. The Department of Psychiatry in the state of North Dakota and other health systems have been working on, expanding telehealth and telemental health services. There's also been development of telehealth skills teaching modules in conjunction with the College of Nursing and Professional Disciplines. Also, we've developed more telemedicine electives, and the family medicine residency programs are teaching telemedicine skills based on competencies from the AAMC. With telemental health, all the systems in North Dakota offer telepsychiatry services, but it's not very well publicized, and they're typically offered to affiliated hospitals and clinics. They are providing telehealth and collaborative care, however, using psychiatry-assisted primary care, and the CPT codes for those can be used for billing at the site. They can also use telemental health services to do screening and brief intervention and referral for treatment, or ESPERT, for mental health. And opioid use disorder. Currently the residency, the psychiatry residency in Fargo is having 3rd and 4th year psychiatry residents providing telepsychiatry services to 10 different sites, 2 in Grand Forks and in a number of different places across the state, including Minot and Williston and Dickinson and Bismarck. With a focus on American Indian populations, they provide services a half a day per week virtually and 1 day per month in person. Also, there are some independent telepsychiatry network, or psychiatry network provides telepsychiatry with an independent group that does provide telepsychiatry to numerous facilities in Minnesota and North Dakota, including Carrington and Breckenridge and Baudette, Minnesota. With our education efforts at UND, we do have the telehealth working group that we talked about in the Robots Project. And we're trying to advance some of that and become a center of excellence for telemedicine teaching. And so what we'd like from you is a little bit of opportunity for you to tell us what you're doing and then maybe where we should go from there. And then I'll turn it back over to Dave to spend the last few minutes we have left here. And sorry about the slide glitches, everybody. For Dave to go ahead and see if we can get some answers to some of those questions and help inform us of what's happening out there.
Well, thank you, Brian. And I'll just make a couple of brief statements. And again, you can see Dr. Delage has actually placed the slides in the chat, so that might be helpful. Maybe we can also put our contact information, but you can find us again on the UND School of Medicine website as well. But I would just offer the fact that as a department chair looking at education of medical students and family medicine physicians in particular, including family medicine resident physicians, telemedicine education is absolutely part of delivering care, but also part of education. One of the things that I appreciate about Dr. Johnson and others at UND is being able to lean on their experience as a resource. If you think back a couple of years, how to understand the nuances of providing care through televideo is really quite new. How to be able to collect objective information, whether that be using devices that now can be connected through video, is relatively new technology. But telemedicine, in the sense of managing information and medical information over the phone, or gathering that information like a home blood pressure or glucose check, is not so new. So it's very interesting to try to take a look at how, when we're working with medical students who graduate medical school and then come into residency programming, are able to be educated in telemedicine. And certainly the pandemic launched that forward, particularly in a couple of our residency programs, both in Minot and Bismarck, for example, the Centers for Family Medicine. And so I really have the ambition that we can be developing these skills together, our practicing physicians as well as those who are still in formal training, that would be part of our goal here. One of our slides actually lists some of the resources, such as the American Academy of Family Physicians Telemedicine and Telehealth resource page. That is open access and can be found on that AAFP website. And there's also specifically resource centers with regard to telehealth resource centers. And I can see in the chat that our Great Plains Resource Center is also funded by HRSA and represents one of those technical assistance resource centers that is really helpful with regard to toolkits and looking at technology as well as building those skills. So these are really important aspects, I feel, is that we're all working together. But I really am very interested in seeing how we can apply these in particular to rural North Dakota. And so that is part of what I'm interested in learning more about, whether you contact us now or again later, so that our department, our faculty, our future physicians who graduate and stay here in rural North Dakota can be sort of ready to go on the job and represent something that is relatively new to someone such as myself, but we have some resources to move the effort forward. With that, any other comments, Dr. Delage, Dr. Johnson, before we wrap up in the next few minutes?
I think the only other thing I had hoped to talk about today is as a provider, if you're not enjoying your telehealth visits, your patients probably aren't either. You need to be able to communicate your personality and a clinical experience through the camera and the microphone. And some of that is just some common sense things. If you want to establish eye contact, you look into the camera, not at the screen. You want to project your voice through the microphone. You should sit up straight. You should have good lighting. You need a private, quiet space where there's not extraneous noise like your dog's barking. You always do this in a private space, never in a public space. Just some common sense things to improve the quality of the visit and satisfaction with your patient.
Thanks for your problems. Hopefully you got those slides and were able to follow some things along. And thanks for the comments in the chat. Please continue to give us some feedback in the chat and send us some questions or some input. We'd appreciate it. And with that, I'll turn it back over to the moderator.
Thank you so much, Dr. Delage, Dr. Schmitz, and Dr. Johnson. We appreciate your talking with us here this afternoon. I don't see any questions at this point, so we'll kind of keep an eye on the chat box in case something does pop up, but we'll move into part 2 of this intensive. So part 2, which is the statewide implementation of the TFCBT telehealth outreach program for traumatized youth. I'd like to introduce Heidi Tupa, who is a licensed clinical social worker in the state of North Dakota. She has been providing mental health treatment to survivors of trauma since 2013. She is trained in the following treatment modalities: trauma-focused behavioral therapy, eye movement desensitization and reprocessing therapy part 1 and 2, with a specialty training for children and adolescents, structured psychotherapy for adolescents responding to chronic stress, traumatized focused cognitive behavioral therapy via telehealth, problematic sexual behavior, cognitive behavioral therapy, and advanced trauma-focused cognitive behavioral therapy for commercially sexually exploited children. She received her master's degree in social work in 2012 from UND. She received her bachelor's degree in social work in 2011 from UND. And she received her bachelor's of science degree in criminal justice studies in 2010 from UND. Disclosure: the presenter has indicated that this presentation will not include discussion of any commercial products or services and will not include any discussion of off-label and or investigational uses of any product or services and will not include trade names. With that, Ms.
Thank you so much for that introduction. It's been a great conference so far. I'm really excited to be here, and I guess we can just get started. So here are the objectives for my presentation. So first I'm going to talk about what the telehealth outreach program is, and I will be referring to the program as TOP throughout the presentation, just to make it a little bit easier for myself. And then I'll be identifying the requirements in order for youth, families, and schools to participate in the program. And then I will be discussing the benefits of trauma-focused cognitive behavioral therapy, or I will also be referring to it as TFCBT throughout the presentation for the TOP for traumatized youth in North Dakota. So here are the list of collaborative agencies in addition to the agency that I am from, which is the Red River Children's Advocacy Center. We also included some collaboration from the Community Violence Intervention Center in Grand Forks as well, because the Red River Children's Advocacy Center does have a satellite agency actually in Grand Forks. And so here is some of the history of TOP. So it was originally funded in 2018 from a grant, and that my supervisor and the executive director of the Dakota Children's Advocacy Center had applied for. And so the clinicians from the collaborative agencies, we were trained in how to adapt trauma-focused cognitive behavioral therapy to telehealth, because by itself, TFCBT is considered to be an evidence-based treatment for children and teenagers in order to reduce PTSD symptoms and get them back to normalized functioning. And so we wanted to get expertise in that area as far as telehealth. And since the Medical University of South Carolina, or MUSC, had done a pilot project and had already gotten this going, we wanted to receive their training. And so we were making sure that we were implementing a program that was not only going to break down barriers and improve access, but also be effective, of course. And so then we officially launched our program in July of 2019. And so more of the history. And so as all of you may know, there is a mental health shortage in North Dakota, especially for the majority of the state that aren't in those counties with major cities. So we have Burley, which is Bismarck, Cass, Fargo, Grand Forks County, which has Grand Forks, Morton, which is Mandan, so very close to Bismarck, and then Ward, which Minot is the major city in that county. And so as you can see, 48 counties are considered to be mental health shortage areas. So what we were finding at the child advocacy centers is that a lot of children are being exposed to trauma but not having access to treatment because they don't live in those areas where mental health providers and services are accessible. And so here is a map of the provider shortage areas. As you can see, the majority of the state is in this blue color, which represents the shortage areas. And so the overall goal of the telehealth outreach program, like I had said before, reducing barriers, improving access to children and adolescents that have experienced trauma, for completing evidence-based therapy services, especially in these mental health shortage areas. And so here are some of the barriers that we were trying to reduce when we had first launched the program. And this is actually a form that caregivers complete regarding barriers as far as our intake process. So lack of transportation, need for childcare, requesting time off or work schedule, of course, no insurance or insurance that maybe doesn't cover mental health treatment, distance to and from the mental health services clinic. And so if you're in rural North Dakota, maybe the nearest clinic is 2.5 hours away, and that's just not really conceivable for taking time off of school for the clients and then time off of work for parents or other caregivers. Being concerned what others would think about seeking services. And so with those rural communities that have access to mental health services, oftentimes there might only be one clinician or one provider. And so as far as confidentiality goes in the community, people may know that you are seeking services, and maybe you don't want people to know that you are seeking mental health services, because there still is that stigma with the majority of the population. Or maybe the provider is your cousin's grandparent or something like that, or other family member, right? And so we know rural communities, there's a lot of people that are related to each other, or a lot of people that know each other. And so sometimes seeking services in those rural communities would be challenging. And then we also have language as a barrier. So maybe the provider doesn't speak the preferred language, and then other. And so this could be any other kind of barrier that they would identify. And so Obviously, in 2020, a big other was COVID, right? And so here's some of the research. Like I said, we received training from MUSC. And there was a pilot study done, a TFCBT telehealth pilot study for school and home-based. And so what they found is TFCBT via telehealth is just as effective as it is in person. And those of you that are from the clinical world probably recognize Cohen and Manarino. So those are two of the founders of TFCBT. And they are currently in Allegheny, Pittsburgh area at the medical center there. And that is actually where I received my training in TFCBT in 2013, was with Judy Cohen and Anthony Manarino. And so, like I had said before, they found results to support the use of telehealth with TFCBT and treatment effects that were very similar to in-person. And so here's more of their research. So they surveyed caregivers on what their thoughts and feelings were about the telehealth experience. And 100% were satisfied with telehealth. Said the level of rapport with the therapist was just as good as in person, and they would recommend telehealth to family member or friend, and 86% said the telehealth equipment was easy to use. And so here I'm going to talk a little bit about referring to the top, and so those of you that are on can just receive more information about, oh, I have this family or this child or teenager that would greatly benefit from TFCBT via telehealth. How can I refer them? And so referrals typically come from past or current involvement with social services, law enforcement, or forensic interviews. So that's typically how children are referred to the CACs across the state. There is an age requirement as well, 7 to 18 years of age. The reason why we chose 7 years old is because that's also what MUSC had done in their pilot study. And like we said, we wanted it to be effective. But a child the age of 7 can read, can be left alone in a room with a provider and are verbal. And so we just felt that age 7 was a good age for starting that. And so there also has to be interpersonal trauma or violence. So for example, a lot of experiences can be traumatic. A parent, suffering from a chronic medical condition, or maybe experiencing a traumatic car accident. But those aren't the types of traumas that we would see at the CACs. We're looking more at sexual abuse, sexual assault, witnessing domestic violence, experiencing teen dating violence themselves, physical abuse, neglect, emotional abuse, human trafficking and sex trafficking, witnessing community violence, and bullying. And I'm going to try to click on the handout. Everyone should have access to this handout, but I just don't want it to kind of mess up my screen here. Okay, so here is the flyer for the telehealth outreach program that everyone should have access to. I'm going to try to scroll down here. Oh, great, I can do that. So it just talks about what is telehealth, some of the advantages. It points out that telehealth is just as effective as in person. According to that telehealth pilot study that I referred to as well. It discusses how it works, what services are available. So first we do a telehealth screening, and so we ensure that there's no logistical issues that could lead to a barrier in a child or family participating in the program. For example, if there's 10 family members living in a 2-bedroom apartment, the child or teenager may not have complete privacy or confidentiality. And so that service might not work particularly for that family. And then we do a trauma assessment, which can be over telehealth as well. And so there we assess symptoms and actually see, is TFCBT an appropriate treatment for this child, or maybe it's not. And then it talks about eligibility, technology requirements, and I'll talk more about that in a second. And then it also goes over what is TFCBT. So what treatment is actually going to be provided? Okay. I don't want to show that one just yet. All right, so I'm going to talk about some of the benefits to TFCBT, and I'm going to try to hurry up here because I think I'm maybe running low on time. So evidence-based TFCBT to rural youth that otherwise would not have access due to barriers. So I have a huge passion for serving rural youth. I was a rural youth at one point growing up in Western North Dakota. So the nearest mental health clinic would have been an hour away. And even though I grew up with a lot of privilege, being from a white middle-class family, receiving mental health therapy services would have definitely been a stressor for my family, even with that privilege. And so I definitely have a passion for those rural youth that are trying to get access to services because they're not from, you know, big city or big communities like Fargo, Bismarck, those types of things. And another benefit of TOP is that we lend out technology materials. And so families don't have to have access to their own laptop or tablet. We can actually provide that if they don't. And it's completely free. We just expect that we get it back at the end of treatment. And the tablets that we send out actually are completely locked down. So it only has the platform available on it that is used for telehealth. And so they can't access the internet. They can't download any apps onto the tablet. We work with a technology company that provides the data packages. And so a family doesn't even have to have access to internet. The tablet doesn't connect to Wi-Fi at all. It just uses the data package. And so being able to provide that, thanks to grant money, has been really great, especially for families that don't have access to technology or maybe only have one smartphone in the family. And a smartphone isn't typically the best method for therapy because we like to keep it really engaging, right? Especially for children and adolescents. We like to be able to use PowerPoint and to pull up books that we read to kids and just to make it really engaging. And so sometimes a smartphone just isn't big enough in order to, you know, do what we want to do within the treatment. And then we also send out teleboxes with therapy materials based on age group. So we have a therapy box for 7 to 9-year-olds, a therapy box for 10 to 12, and a therapy box for 13 to 18-year-olds. And so the majority of the materials are the same, just with some subtle differences. And at the end, if we have time, I do have a 10 to 12 box that I can go through and show you what is actually in the box. And so you can see what the child or teenager will be receiving. And then another great benefit is that we do free returns of technology materials. And so, for example, if a family is, 3-4 hours away, they don't have to drive to drop off the materials or return the materials back to us. And so what we do is we have a contract with a local mailing system company that has been really great. And so we send out prepaid boxes to families. And so the family will get a box, and then inside of it will be another box that's already prepaid. So all they have to do is put the tablet and the charger back in the box and drop it off in the mail. And so they're not responsible for having to pay to mail it back to us. And another benefit from TOP is that youth are more likely to complete or graduate from treatment. And so I'm going to go over some of the outcomes from 2019. So since we were funded by a grant, we had to track data, of course. Everybody loves that, but that also allows us to see the efficacy or how effective the program is and what else we need to do in the future to improve the program. And so everyone should have access to this handout as well, but I will just click on it here. So here is the Telehealth Outreach Program 2019 Annual Report. So since we started it in July of 2019, so it'd be from July 2019 until December of 2019, so just shy of 6 months. So 39 clients were served, 32% of counties were served in North Dakota. There was 111 therapy sessions, 173 mental health services were provided. It also goes over the age, the other demographics, sex, race, and type of abuse as well. And so the majority of kids that were served were ages 7 to 12. Following that would have been 13 to 17. And then as far as race goes, pretty similar rates of white people in the state of North Dakota, 73%, but obviously disproportionate for the Native American population, 21% of them were served. And I think there's only about an 8% population in the state of North Dakota. But obviously we know that the Native American population experiences a lot of trauma, especially with intergenerational trauma impacting the lives of youth. And then we have types of abuse. The majority of abuse that we typically see at child advocacy centers is sexual abuse or sexual assault. Other could also be experiencing teen dating violence or witnessing community violence, neglect, emotional abuse. And so the majority of youth were served in their home, 61%, and 39% were served at their school. So about 56% of the clients that were served were on Medicaid or had no insurance. And 100% of the clients that completed the survey said that they would use telehealth again if therapy was needed again in the future. And a big component that I like to point out is decreasing the barriers, for example. So 71% identified that a barrier was distance, 19% identified their barrier was work, and 10% was transportation. So either a lack of transportation or even a lack of financial resources for gas. and there was 182 average number of miles saved per session. So that is also a really exciting number as well. We're reducing the amount of time that family is in the car and more access to services. And about 51% of the clients that we served had more than one barrier to services as well. Okay. So that was the 2019 report, like I had said, and I keep clicking on the screen. So I'm just gonna take a drink real quick. So now I will be referring to the 2020 annual report. And so obviously there's a huge increase because of COVID, right? And so we expanded access to telehealth for not only TFCBT, but our other treatments that we provide as well, such as PSB-CBT or problematic sexual behavior, cognitive behavioral therapy, and other adult treatments that we provide at the Child Advocacy Center, because our agency had to be closed from about I would say 3 months or so until we were able to start slowly trickling in people back into our clinic. And as other agencies and other providers were kind of, scrambling to implement telehealth, we had already had this structure because our program had started in 2019. And so we just really worked hard on expanding it and doing the best we could to serve people with extra barriers of COVID and the fact that our clinic had to be shut down for a period of time, as most clinics and things like that. So in 2020, 353 clients were served, so about an 805 increase from the 6 months that we had done in 2019. Over 1,000 services were provided, almost 2,000, about like 1,800 therapy sessions were done as well. Really exciting that 57% of North Dakota counties were served, 4 Minnesota counties and 3 reservations as well, which was a 56% increase from 2019. And also with the demographics, what we saw is more ethnicities and races being represented. And so only 69% were white or Caucasian, 16% were Native American. We saw 5% African American, 6% Hispanic or Latino, and then 4% identified as other. So maybe they identified as biracial, so or of a different race than what we have listed. And same as 2019, the majority of the type of abuse was sexual abuse as well. And so we did some training that was exciting as well. So kind of teaching other professionals about telehealth, and so there's about 1,800 professionals that were trained and 43 presentations were done. Obviously, the majority of those being virtual, of course, because of COVID. And no surprise, one of the top barriers was COVID, distance, and work, similar to 2019. Besides COVID, there was 78 average number of miles saved per session. The reason why we saw a decrease in the average number of miles is because we were serving our children and families are actually in the Fargo-Moorhead area because of COVID. So we weren't just serving rural families across the state, we were serving families that were maybe 2 miles away but couldn't come to our clinic because of COVID. 27% of clients had more than one barrier. Again, 100% of clients said that if therapy were needed again, they would utilize telehealth, which is amazing to see because the satisfaction of our clients and their caregivers is the most important thing. And so kind of here's some more information about the regionalization project of 2020, so expanding the statewide telehealth outreach program. So some of our goals, again, things that I had already talked about. A great project impact, of course. And then kind of some future things that we are currently working on. So there's still a lot to do, obviously, because 90% of the state is considered to be a mental health shortage area, and we only covered 56% of the state. And so in my opinion, once 100% of the state is covered, then we've completely reached our goal. We also want to increase capacity by adding an additional telehealth therapist, especially at the Dickinson and Grand Forks satellite sites, because they're often at capacity and have wait lists. I actually served a client from the Dickinson area being all the way here in Fargo, and it worked great just because I had some openings. But having more clinicians trained in that or on that side of the state would definitely be beneficial, especially also, you know, in the Williston areas where there's a lot of need as well. And also with more funding, we could purchase more equipment, which could reduce barriers for families for them not having to utilize their own technology. And then with also more funding, we could provide more advanced training to the therapists to increase their skill level and make them even more effective with telehealth and TFCBT. So that's the 2020 report. And so here's the map of the impact. And so the green dots would be where we've served clients. I think I'm missing a few counties as well. Since I made the presentation, I think we've served more counties. And so I don't think this slide is 100% accurate. So I apologize for that. And so here are some resources. So I utilized part of a presentation that my supervisor had done. And then also I referenced the telehealth pilot study. And so thank you very much for your time. Feel free to contact me with any follow-up questions. I'm more than happy to answer any questions or provide any information that would be helpful. And it looks like I have a question. Are you willing to share your annual report? Yes, it should be as part of the handouts. I did provide it to Amy and Kylie as a handout. So you already should have access to that. Or you can also send me an email and I can email it to you as well if you would prefer that. And since I do have a little bit of time, I wanted to share one of the boxes. So like I said, this is for ages 10 to 12. So I'm just going to show you some of the materials that we have in this box.
Heidi, do you maybe want to stop sharing your screen so they can see you a little bit bigger with the box?
Oh, yeah, I can definitely do that. Sorry about that. Okay, great. So here we have a SUD scale. So this is very tactile for kids. So just ask them how they're feeling and then rate on a scale of 1 to 10. And so the first feeling would be happy, second feeling scared, angry, and sad. And so they would just, I must have grabbed a box that didn't have beads on it. So there's supposed to be beads. And so then the child can move the beads and identify. And we have tissues because sometimes doing trauma therapy, there are some tears. And so I don't know any 7-year-old child that has Kleenexes in their room. And so we want to make sure that we have Kleenexes for them if needed. Relaxation. So in here we have materials for kids to make their own stress ball. And that's a really fun activity. It can be really engaging for them. There's also bubbles to practice deep breathing and a silly putty for them to use for stress. We have some art supplies in here as well. So colored pencils, markers. There's also cardstock paper in here. And so they can draw, write stuff down, whatever they would like to do for that. There's some colored note cards. And so they can write down positive affirmations, or when we do cognitive coping, then they can write down a helpful thought, an unhelpful thought. We have a progressive muscle relaxation kit. So in here, there's a script as well as the little pictures that kids can carry around in their pocket to help them practice progressive muscle relaxation. There's also a journal in here. A lot of the journals are more gender neutral because we do have all genders participate. And then pens, pencils, so they can write stuff down. And then, like I said, cardstock. And so some of the boxes are different depending on the age of the child, but the majority have similar items. So I just had grabbed the 10 to 12 to show you. And I think that is all I have. So thank you very much. Any questions?